In a previous lecture in this series, Dr. Addy made mention of Dr. John Snow, a British physician who lived in England in the mid-1800s. Dr. Snow interrupted the 1854 cholera outbreak in London using classic epidemiologic detective work. He literally mapped the occurrence of new cases in the city of London, as shown in this illustration of his map. This is perhaps the first instance of GIS mapping. The spatial pattern indicated the cause of the epidemic was a town water pump whose source of water was polluted with the cholera vibrio. Dr. Snow's successful solution to the outbreak was to remove the pump's handle, preventing individuals from drawing the polluted water. That's public health in action, and an example of how clinicians were involved in efforts to improve the population's health. Precision medicine is a relatively new concept that was brought to the attention of the scientific community in a 2011 National Academy of Science report entitled Towards Precision Medicine, although it was certainly a concept around before then. Precision medicine is an intermediate step to personalized medicine, that is, medical care provided to an individual patient based on the uniqueness of that patient. Currently, personalized medicine is largely defined in terms of the patient's genetic profile or genotype. Precision medicine is the tailoring of medical care, or more broadly health care, based not only on the patient's genotype, but on their phenotype, as these characteristics relate to the susceptibility to disease prognosis, or response to therapies. This knowledge is discovered through clinical experience with many patients. The goal of precision medicine is a more personalized medical care, but it also has the goal of developing a knowledge base that leads to new diagnostic tests, new therapeutics, or new technologies. To understand how population health can contribute to advances in precision medicine, we must look more closely at the concept of precision medicine. Let's begin by setting the context. Medicine as a discipline has always been highly personalized. That is, it is care provided in accordance with the needs and wants of the individual patient. However, the dream is to use the patient's unique characteristics to provide medical care truly driven by the uniqueness of that patient. In 2003, something unique and profound occurred. The human genome was fully decoded. This raised the possibility and hope of achieving the highly personalized medical care of personalized medicine in the near term based on the genetic profile of the patient. But progress to personalized medicine has been incremental. Why? We are finding it much more difficult to identify the genetic connections in the occurrence of disease and in response to therapies, and in devising ways to counteract those effects. We are also realizing that behavioral and social factors influence health in ways not previously imagined. As we noted earlier, in 2011, a possible pathway to more personalized medical care, precision medicine, emerged on the scene. The potential of precision medicine to improve healthcare may be best recognized when the promise and problems of personalized medicine are understood. The promises of personalized medicine are summarized in its characterization by 3 Ps. It is predictive, that is, the individual's genome is predictive of disease or the likelihood of experiencing a given condition. It is preventive. By knowing the early indicators or markers of impending disease, we can take preventive action. And it's personalized. That is, it is the individual's health versus that of a population of patients, even if the population being considered is relatively small. The implications is that the therapies and other actions are specifically designed to address the health situation of a given person and that person's responsiveness to available treatments. We are now acutely aware that personalized medicine is a Pandora's box. For one, despite increasing talk of the $1,000 genome profile, it remains costly to get a genetic profile, and most patients have not had one done. For another, the role of genetics and proteomics for many, perhaps most diseases and conditions is far from certain. There is also recognition that genes can be switched on and off by environmental factors, including those from the individual's social environment. This is the emerging field of epigenetics, to which we shall return shortly. As yet another challenge, and a particularly troubling one, is the area of incidental findings that presents a set of ethical, legal, and social issues. Let me ask you this. If your mother or brother or sister underwent genetic testing, would you want to know the results of the test if it would indicate you had a high likelihood of developing a disease? Would it matter if there were a treatment for the disease or that it was preventable through certain action? In analyzing a patient's genome for one condition, the propensity for developing other diseases or conditions may be identified. Of particular concern are diseases or conditions for which there is no effective therapy, such as Huntington's disease or familial Alzheimer's disease. In contradistinction, there is relatively less concern when there are effective therapies or preventive treatments that can be taken. For example, a woman knowing that she has the BRCA1 gene that puts her at high risk of developing malignant breast cancer can take preventive actions to reduce that likelihood. Precision medicine is medical care driven by the molecular biology of disease. As mentioned earlier, the genotype-phenotype of similar patients guides the content of care. This may entail undergoing a certain diagnostic evaluation to determine if the patient has a biomarker that indicates susceptibility to a given disease. It may also involve assessment of whether the patient will be responsive to a given drug or have a poor reaction to it. For example, a sample of a patient's tumor may be assessed for responsiveness to several chemotherapies in order to select the one that will have the biggest effect on the patient's tumor. Some have suggested that precision medicine adds a fourth P to those of personalized medicine. That P is participatory. The patient should be an informed partner in the medical decision-making. This is a key element of patient-centered care. The Institute of Medicine defines this type of healthcare as care that involves healthcare processes that ensure decisions respect patients' wants, needs, and preferences, and for which patients have the education and support they need to make decisions and participate in their own care. A fifth P proposed is that of population, as in screening a population for a biomarker that indicates presence of a disease in order to prevent or interrupt that disease. In this cartoon, we see the various components that together lead to more precise medical care. We have clinical observations arising from the provider-patient interaction, that is, from the course of care, that reveal patterns in susceptibility to disease, prognosis, or responsiveness to therapy. These observations also reveal social and behavioral factors, as well as attitudes and beliefs that may impact the risk of disease, and perhaps more importantly, also impact the care being provided. Moreover, there are patient preferences for care. Patients may not wish to have a certain therapy despite its potential effectiveness for them or because of side effects. Or they may be fearful of the treatment. Moreover, patients may not be adherent to the treatment because they are forgetful and have no one in the home to assist them in taking their medications properly. These observations feed into what has been defined as the information commons. This knowledge repository is parsed or grouped into succinct subsets of information, as conceived by the Precision Medicine Work Group. In this cartoon, we see the various components that together lead to more precise medical care. We have clinical observations arising from the provider-patient interaction, that is, from the course of care, that reveal patterns in susceptibility to disease, prognosis, or responsiveness to therapy. These observations also reveal social and behavioral factors, as well as attitudes, beliefs, and preferences that may impact the risk of disease, and perhaps more importantly, also impact the care being provided. Thus, patients may not wish to have a certain therapy despite its potential effectiveness for them because of the side effects or because of fear of the treatment. Moreover, patients may not be adherent to the treatment because they are forgetful or they have no one in the home to assist them in taking their medications properly. These observations feed into what has been defined as the information commons. This knowledge repository is parsed or grouped into succinct subsets of information. As conceived by the Precision Medicine Work Group, we have the areas of exposome, that is the full array of environmental exposures, signs and symptoms of disease, the genome, epigenome, microbiome, that is microbes that are upon and within one's body, and what I think of as the kitchen junk drawer category, comprised of other types of patient data. These subsets of data are interconnected by a knowledge network that identifies important patterns or associations between factors, providing insights by which to improve the clinical care being provided and thereby improve health outcomes. When these data are also mined by those of the laboratory sciences, there may emerge better understanding of the molecular mechanism of disease. It is how a disease has its effect and how to interrupt that process, or it may yield markers, that is, biomarkers of susceptibility to a disease, or of prognosis, or of responsiveness to a therapeutic agent. And third, the data may lead to the identification of a drug target for which we might develop new therapies. Clearly, there is a role for computing sciences that can assist in the organization and analysis of the data to arrive at the patterns we are seeking. Neural network analysis comes immediately to mind as a means of determining an individual-specific answer to a clinical question of a provider, such as, will this patient respond to this antidepressant drug, or do I need to consider another one? We see there is also a box marked population health that feeds into the information commons. This is our primary focus today. Let's explore this connection in more detail. How exactly does population health science either contribute to the information common or allow for more insightful analysis of the interconnections of the data through the knowledge network? Population health provides evidence on the associations with disease of various factors, whether those factors are behavioral, environmental, societal, such as laws and policies, social or socioeconomic in nature, or the healthcare delivery system. Population health can also inform us as to those factors that may affect the outcome of treatment, such as adherence to therapy, or playing an active decision-making role in deciding upon the treatment plan. These factors are interrelated as conceptualized by the ecological model of health and disease. This model is often represented in many different ways, but what it makes explicit are the connections between non-medical factors and occurrence of illness. These factors are interrelated as conceptualized by the ecological model of health and disease. This model is represented in many forms. Here we see a version focused on understanding health behaviors. But regardless of its form, the ecologic model makes explicit the connections between non-medical factors and the occurrence of illness. We must not forget the role of the unique factor of population health, that is, its inclusion of the healthcare system as a factor affecting health. Through its focus on the healthcare system, population health may contribute to more precise medical care by providing evidence on the role of non-medical factors in terms of response to specific treatments. This is in addition to providing evidence on how care may affect the risk of disease, such as a patient's willingness to undergo screening to detect disease. To better understand how population health contributes to precision medicine, let's begin with the exposome. The definition of exposome is the totality of exposures in the environment that the individual experiences over their lifetime. Obviously, for precision medicine, we consider only those exposures experienced up to the point at which the individual is seeking care. Environmental exposures are the traditional focus of public health, as we saw with the example of Dr. John Snow and the 1854 cholera outbreak in London. To make our discussion more concrete, let's look at a number of specific examples. A couple of these topics emerged recently in the press. The classic example of an environmental exposure is that of lead paint. Infants and young children are typically exposed to this environmental hazard in older homes where this type of paint has yet to be removed or covered over. These homes are typically rental properties in the inner city. The exposure often reaches toxic proportions where there is an acute reaction by the child, but it may also be a low chronic type of exposure that results in development of neurologic problems. Of concern is whether these children with chronic exposure to lead experience problems as they age, particularly problems that may arise from the subtle neurologic deficits associated with lead exposure as children. Antisocial behavior has been linked to long-term exposure to lead. Recent studies by University of Cincinnati investigators explored whether children exposed to lead paint had longer-term consequences in terms of engaging in criminal behavior as adolescents or young adults. As shown in this set of graphs, there is a strong direct or positive correlation between arrests for violent crime in late adolescence and early adulthood and the levels of blood lead exposure while in the womb, which is shown in the upper graph, the average blood lead levels during their first 6 years of life, shown in the middle graph, and the blood lead levels at age 6 or so, the lower graph. It is a problem of continuing relevance as lead poisoning of children remains far too common. For precision medicine, the challenge is to use the information on childhood lead exposure to craft a treatment plan that might counteract these effects, whether the treatment is behavioral in nature or medical. Recently, the press reported on the results of an intriguing set of experiments that studied the effects of the use of artificial sweeteners on the development of glucose intolerance, a condition that is a precursor to diabetes. The conclusion was that those who used artificial sweeteners consistently or exclusively may be setting themselves up for development of diabetes. Let's look at the emerging evidence. We see here the complex study design by which the investigators attempted to determine if the use of sweeteners will result in glucose intolerance and whether that effect is achieved through the modification of the microbiota of the gut. Basically, the issue was explored by 1. Assessing changes in glucose tolerance when there was high use of artificial sweeteners. 2. By assessing changes in the array of the microorganisms under the use of artificial sweeteners. 3. By assessing what happened when these microorganisms were killed off. And 4. Assessing whether glucose intolerance could be induced in other mice by transplanting the gut microbiota of the glucose-intolerant mice into unaffected mice. The key graphs for us are those in the middle column, graphs B and E. These graphs compare the area under the curve of the glycemic response of the animal. To understand the concept of area under the curve, look at graph C. We are looking at the size of the area under the line indicating the level of blood glucose over time. A greater area is found if the response of the animal is a higher level of glucose in their blood for a longer period of time. In graph A and the first 2 columns of graph B shows that mice who received a steady diet of saccharin, that is, an artificial sweetener, versus one of glucose, graph A, or water, the first column in graph B, had significantly higher blood glucose levels over time, reflecting their inability to normally manage their blood glucose levels. The investigators then looked at the gut microbiota and found that those mice on artificial sweeteners had developed a different array of gut microorganisms than those who drank glucose or water. In the last 2 columns of graph B, we see what happens when the animal's gut biota are wiped out by antibiotics. Essentially, the mice on saccharin were able to manage their blood glucose normally when their microbiota were killed off. That is, they were similar to mice on water, which experienced no change in their glucose response. Now the interesting part, as if the findings thus far are not interesting enough. To complete the assessment, the investigators transferred the gut microbiota of mice on artificial sweeteners or glucose to other mice who had had their gut microbiota wiped out. As shown in graph E, the mice receiving the gut microbiota from mice using artificial sweeteners exclusively also began to show inability to normally manage their blood glucose levels, while those who had received the gut microbiota from glucose-fed mice were just fine. To summarize, population health can help clinicians to understand how the health of their patients are affected by environmental exposures, including those that may be viewed as benign, such as the use of artificial sweeteners. Let us now shift our attention to the determinant that distinguishes population health from traditional public health, the healthcare system. Precision medicine will be developed in an environment that is increasingly patient-centered, which is exactly the most appropriate context. We have already mentioned that precision medicine involves an educated patient who is actively participating in his or her care, the fourth P. And patient-centered care, as we noted, involves patient-provider interactions that ensure decisions are made that respect the wants, needs, and desires or preferences of the patient, and for which the patient is an educated partner in making the decision, to the extent they wish to be so. Under precision medicine, the patient will be an informed partner in the treatment decision-making, identifying the therapies that seem to be most effective for patients like them. Thus, one way in which the healthcare system influences health is by its effect on the type of care received. That is, whether the most appropriate care is provided to the patient. Another way in which the health system affects the health of individuals is through access to that very care. In this cartoon, we see the evolution of the U.S. healthcare system, at least as those at the Centers for Medicare and Medicaid Services envision it. We are currently in version 2.0, where the emphasis is on patient-centered care in an accountable care context. The Accountable Care Organization is a trial concept that the federal government is exploring. It supposedly yields more appropriate and therefore more effective care by coordinating the primary and specialty care of the patient. Although it is often viewed as improving quality, its goal is really a financial one, more efficient care. Version 3.0 is where we are going, in which the healthcare system becomes responsible not only for the health of those who are enrolled with the system's providers, but also that of the communities from which those patients are drawn. Why? Because as we saw under the ecological model, many non-medical factors influence health. I am especially intrigued by linking patients with resources in their communities to maximize, say, their recovery from an illness. We are talking here about personalizing the patient's care to his or her social circumstances. To illustrate this point, let's consider congestive heart failure, or CHF, which is one of the initial conditions of interest to the Centers for Medicare and Medicaid Services in assessing quality of care and in penalizing hospitals for failure to achieve benchmarks. Here, the benchmark is not to have the patient return to the hospital within 30 days. Early return among CHF patients may reflect poor discharge planning in terms of the patient going back into a home situation without the proper assistance. If the caregiver is unable to provide the care required to keep the patient out of problems, such as fluid buildup, having someone from an assistive agency come in daily to assess the patient may well result in the patient staying out of the hospital. Of course, research is needed to prove that this approach to providing care does indeed improve health and can do so efficiently. Currently, the promise of precision medicine is just that, a promise. The healthcare arena is posing some formidable challenges to the implementation of precision medicine. Let's look at some of the key challenges. In the United States, our healthcare delivery infrastructure has competing tensions, which I represent somewhat whimsically as a yin-yang phenomenon. Yin is dark, cool, and feminine, while yang is bright, aggressive, and masculine. As illustrated by the intertwining symbol, yin merges into yang, and yang merges into yin, and both have a bit of the other within them. Here I use yin to reflect the healthcare delivery system by which to deliver precision medicine, while Yang reflects advances in medically related knowledge, which is the content of precision medicine. The delivery system has the interrelated challenges of increasing access, decreasing costs, and improving quality of care. And while these are all viewed as important, I believe that it is fair to say that cost has attracted the most attention. On the other side, medically related knowledge is producing new diagnostic tests, new therapies, and new technologies by which to improve health outcomes, but at a price. This graph depicts the actual and projected costs of healthcare in the United States over a 30-year period, beginning with 1990. These data come from the much-respected Kaiser Family Foundation. Even a casual observer will conclude that the cost of healthcare in the United States is on an upward trajectory, and that trajectory may well be unsustainable. These data were compiled prior to the Patient Protection and Affordable Care Act of 2010. That act seeks to provide universal health insurance coverage for U.S. citizens. One of the touted benefits of that act is that it will bend this cost curve. Emerging evidence regarding the actual impact of the Affordable Care Act indicate no such bending of the curve. Healthcare costs appear to be continuing their rise as predicted. This should not be a surprise, as the Affordable Care Act is a conversation about how to pay for health care rather than the cost of that care. Let me ask you another question. What do you believe is the number one source of healthcare costs? Would that be doctors or hospitals or pharmaceutical companies or maybe long-term care? I think the answer may surprise you. This schematic shows the sources of the cost of care in proportion to each factor's contribution to overall costs. Notice the three major sources of healthcare costs. In descending order, we have hospitals, doctors, and prescriptions. Hospitals and doctors are the major components of the Accountable Care Organization initiative that CMS is exploring as a means of reducing the cost of care. We will see how that works out over the future. Prescriptions and the drug industry has long been the preferred target of healthcare critics as being responsible for the rising cost of care. With recent pharmaceutical advances, there may be some truth to the belief. Of concern to us in precision medicine, there are various efforts to rein in prescription costs, but these have negative implications for personalization of healthcare treatment. Under precision medicine, we want the patient to get the best therapy for them. It may be the more expensive treatment, but it will be the treatment they are most responsive to. This tension between the cost of therapy and the effectiveness of therapy is currently being played out in the Arkansas Medicaid program regarding the use of drugs for the treatment of hepatitis C. Hepatitis C is a chronic infection of the liver that is highly prevalent among my generation, the baby boomers. The reason for this epidemic is not fully clear, but may well be a consequence of the high prevalence of injection drug use in these individuals during their younger days. Regardless, if left untreated or insufficiently treated, those infected go on to develop liver cancer and experience a high premature mortality rate. Several new drugs have come on the market to treat hepatitis C. One drug by Gilead Sciences is called Sovaldi, and the other is Olysio by Johnson & Johnson. These new drugs are highly effective, require a shorter period of treatment, and have fewer side effects. Moreover, the drug is delivered in pill form. This is in contradistinction to the current therapy for hepatitis C, which is interferon. It has about half the cure rate of the newer drugs. As important, it requires weekly injections for a year and has severe side effects. However, it is considerably less expensive. Here we see a summary of the positive and negative aspects of the alternative therapies for hepatitis C. I think this comparison makes the benefits and harms of each of these therapies quite clear. The Arkansas Medicaid program has taken the stance that Medicaid patients must be started on the older therapy, and if they fail it, then they can receive the newer therapies. The goal is cost control in the near term. We will see how that plays out. The dangers are obvious. Delayed therapy may allow the disease to progress. It also imposes undue pain and suffering on the patient. This is not an isolated stance. Arkansas Medicaid is also struggling with whether to pay for other newer but more expensive drugs, such as a new drug for cystic fibrosis that comes with a hefty price tag. Beyond costs of care, there are a number of other issues, but we won't spend much time on them. These are emerging, that is, they are on the horizon, but may not be fully manifested until new policies go into effect to increase access to care, control costs, or attempt to improve outcomes. As one issue, what if guidelines by which providers are rewarded if they adhere to these best practices conflict with what the patient wants in terms of care? This is being acted out in the treatment for breast cancer, where women are opting for bilateral mastectomy when cancer is found in only one breast. Best practices call for lumpectomy. Providers are worried that this phenomenon is being driven by fear in an uninformed patient. If so, a solution is obvious. But what if other patient factors are involved, such as preferences for care? As another issue, what if a drug that is on average the best doesn't work well in a particular patient? Maybe another drug, one that is deemed less effective relatively speaking, is a better one for the patient, but it might not be paid for by insurance companies because it is, quote, the less effective drug. The patient may end up paying for the treatment out of pocket, but if without resources, the patient may have to forego their more effective therapy. These are just some of the real issues on the horizon. So where do we go from here? If we are to advance the implementation of precision medicine, there are a number of steps that need to be taken. For one, while there is an increasing number of centers for personalized medicine and precision medicine, these centers are largely focused on using genomics to determine responsiveness to therapy. The broader aspects of precision medicine remain to be developed. For another, the key components of precision medicine, the information commons, and the knowledge network, do not yet exist. This is not to say that those from laboratory sciences or computing sciences or public health are not working with clinical medicine. They are, but it may be in less efficient ways than could be if we had an information commons and knowledge network. And third, we need a workforce to do the work. This will require interdisciplinary training so that those of the various interrelated disciplines necessary for precision medicine to succeed will know how to work together. So much remains to be done. We are in the exciting times wherein the great potential of precision medicine can be advanced.